Hi, I'm Dr. Stephen Allison. I'm an ophthalmologist with over 25 years of clinical experience, and I'm very involved with the teaching of pre-grad and postgraduate students in ophthalmology. And I have, over the years, seen many things come and go, but the most important thing is the fundamentals stay the same. The pearls stay the same, and the approaches stay the same. And if we have good approaches and good pearls just as cornerstones of our treatment, we can be very, very, very good and effective doctors. So here are some of the pearls that I have picked up over the years and approaches that will help you, because I know what it's like to stand in front of a patient and you go, he's nauseous, and you don't know what to do about it because you've got all this knowledge, but you have no approach to something basic like that. So just to strip away everything is, remember, as always, function is everything. So, and one tends to get caught up, especially in the modern times, caught up in I don't have the equipment. I can't examine this guy's eye. I don't have the equipment to do that. Now, I'm saying you can get to 99% of all diagnoses with very, very basic tools. In fact, no tools at all. As an example, first thing, you need a red object, any red object for color vision. There you go. You need a light, any light, not even an ophthalmoscope, any light, and you can examine an eye really, really well. What you need is a marking on a stick, on a sushi stick for proptosis. You can really get away with it, and I'm going to show you how to do that. The other thing is corneal sensation. This is your corneal sensationometer, is a tissue. So quite incredible. So let's go on this exciting journey to unlock the eye and show you that it's really not as alien as you think, and that most things are treatable and at least manageable in the appropriate way. So someone comes into your office or is in casualty and he's got a problem with his eye. What is the most important thing? The most important thing in everything when you're examining an eye is function. Function, function, function. That's it. Because that separates the men from the boys. It means if someone's eye looks terrible but functions well, no problem. If someone's eye maybe looks okay but the function is gone, you should be more attentive. So function is everything, because the thing about function is that it's also a standardization. In other words, you can give a line in the road. So when you want to actually, say, refer the guy or see how the treatment is going, any of those things, you need to have the line in the road. You need to know what was his function when he arrived in your office or when he arrived in casualty. That is of cardinal importance. And we need to standardize it so that you can phone someone in a different country and say, this is what I've got, or email them probably, or video chat them, phone. I'm giving away my age here. That you can video chat someone in another country and he knows exactly what you're talking about, because you've got a standardized approach to the function of this eye. So the first video is going to be about determining the function of the eye. We may, though, when I do, get a bit sidetracked and wormhole down some paths which are interesting when they come up. It's better than compartmentizing it any other way. If something pops up and I feel like wormholing down it, I'm going to do that and share with you some of the interesting points. Right, so function, you know, you don't need fancy tools for function. What do you need to determine the function of an eye? Basically a Snellen chart. A Snellen chart's probably the way to go. If you can use a Snellen chart, most places have a Snellen chart, this sort of thing. This is where you have the letters getting smaller and smaller with little fractions on the side here, and those little fractions standardize the function of the eye. So what do we do when we stand the patient? Now, when you look at the side of the Snellen chart, you'll see little fractions. You'll see little fractions there. Now, those fractions are numerator, denominator, numerator, denominator. And if you notice, the numerator, the little number on top of the little fraction, the numerator, is basically always a standard figure. In other words, it will be 20 something, 2020, 2200, 2050, and so on, or 66, 675, 69, 612, right up to 660. You'll notice that the top number always stays the same. Now, why does it do that? What happened is, to give you the history, it's basically you comparing your patient to Snellen's assistant, who was probably normal. So what Snellen did is he said, well, I've got an assistant, he sees well, you stand here, let's see what you see at a certain distance. And we now compare our patient to the normal patient. In other words, it's a comparison. So you can also be better than normal because your vision may just be a little bit better than the normal patient, because what is normal? So the top number will always be where the patient stands. So the 6 stands for 6 meters, the 20 is just 20 feet, whether you're American or whether you're metric. So 6 and 20/20 vision are the same thing. So what does the denominator mean? The denominator, or the bottom number, means how far a normal person can stand to see what your patient is seeing. Simple as that. So in other words, your patient stands at 6 meters or 20 feet, and he looks at the Snellen's chart and he gets to a certain number. Next to that number is, next to that certain letter, there's a number that says, say, 20/40. No? 20/40 or 6/12 vision. So what does that mean? That means that your patient is standing at 6 meters, and a normal person would be able to see what your patient is seeing by moving back to 12 meters, and he can see what your patient is seeing. So that means your patient sees poorer than the normal by a certain amount, poorer than normal. So what does 6/5 vision mean, or 20/15 vision? That means when your patient stands at 6 meters or at 20 feet, a normal person would have to crawl forward a little bit to see what your patient is seeing. Therefore, your patient is seeing better than normal. So it's just a comparison to normal. So that's what those fractions mean. Why is it important to have those fractions? Very important, because that's a standardization. Then you can video chat the guy overseas and he'll know exactly what the vision is. When you follow up the patient, you know exactly what his vision was and what it is now. And that quantifies it properly. So that's very important. In the modern terms, we actually use decimals, 0.1 vision, 0.2, 0.3, 0.4 until 1 vision, which is just a decimalization of a similar system. So that's what your Snellen chart is all about. Now you get to the situation where the guy looks with the one eye. I always do one eye at a time. Let him close the one eye, let him close the other eye. Remember, he has a little trick that they normally do. If someone knows that he can't see with the one eye, he goes, close your right eye. And then he says, okay, close the other eye. Then he does this. What a little trick. You're still looking with the one eye. Do you see that? So watch out that the patient doesn't cheat, and that he doesn't look through the little gaps in his fingers when you do cover him. So cover him properly. It's very important that, so that they don't cheat, so that they, if you're doing normal examinations. Normally, if someone is in casualty or injured or has some other eye problem, he won't cheat. But it's very important that you actually get the reading of that eye. Very important. Right, so now you've quantified the readings, and you get to the top E, the big one at the top, that's 660 or 2200 vision, and he still can't see that. So what does that now mean? Does that mean he's blind? No, it doesn't mean he's blind in that eye. You've got to quantify it further. What's the next step? The next step, if you can't see that big E at the top, the next step is to ask him whether he can count your fingers. Okay, so you go a meter away from him, a meter away from your patient, and you say, can I count my fingers? And he counts the fingers, and you test him a couple of times, and he can count the fingers. That is a quantification. You say, can count fingers at 1 meter, or finger counting at 1 meter. If he can't do that, the next step is, does he see the movement? Can he see? So it's hand movements at a meter. All right. The next step down from that is, does he have light perception? Because what's very important about vision, something that one mustn't forget, is that vision is a subjective thing. It's not an objective thing. So in other words, the patient has to tell you what is his vision. You can't catch him out even. If he says he can't see it, he can't see it. Or if he can see it, he can't see it. So another important point when you do visual acuity, is to make it easy for the patient. Remember this little point, that if you don't make it easy for the patient, he's going to give you an incorrect reading and you're going to make an incorrect assumption. So what's very important is children. We mentioned children just now. Children are very important. Remember that it's not a reading test. If they struggle with reading, say no, he's a dyslexic or something, and he has problem reading and he's a little bit nervous and he sees the E but he doesn't know what to call it and this little thing, and then you think he can't see it. What you do is then you go to the illiterate chart. You go to the illiterate chart, which is just normally on the flip side of this one. You go to the illiterate chart and you show him, show me this way, show me that way, show me that way. And this helps a lot with illiterate and with children, so that they are comfortable with the fact that they don't have to actually read the thing. So it's not a reading test, it's a seeing test. You want to test his vision, and it's subjective, so you've got to bring him on board. You've got to make it easy. You've got to make sure that he doesn't think that it's a reading test or that it's in some way testing his intelligence. You just want to test his vision, so you make it as easy as possible. Very important that. Relaxed patient, easy, use the illiterate chart if you have to. Right, so now we're down to hand movements, we're down to light perception. At light perception level, we can start catching him out, whether he says he can see or not. If he sees nothing, he says, I can see nothing, and you shine a light in his eye and you say, can you see the light? And he sees the light and you take it away and he doesn't see the light, that's fine. Then he's got light perception. Okay, light perception is also a very important thing. Here's where you can start catching him out. We'll speak about this in subsequent videos when we talk about pupil reaction. When we do that, is you shine a light in his eye. You take your little light and you shine it in his eye, and you shine it in his eye, and you take it away and you ask him, can you see the light? Can't you see the light? Can you see the light? Can you see the light? Catch him out. Don't get a rhythm going, because he can sometimes feel the heat of the light and give you the incorrect thing. But the way to catch him out is that when you shine a light in his eye and his eye can see that light, the pupil constricts. So if he says he can't see the light, but the pupil constricts, he's lying. And you need to record that the patient was relatively uncooperative, but on objective vision, he has got light perception. Okay, so that's only at that level can you start sort of catching him out and finding little ways to be. The next level after light, the reason why I'm laboring this point a little bit is because the difference between light perception and no light perception is a massive divide, a massive divide. So if you write in someone's file, no light perception, you have made a massive diagnosis. Why? Because no one comes back from light perception, from no light perception. No one comes back from that. Once it's dead, it's dead. And therein lies our problem. So once you write something in the file, you must make sure, does he or does he not have light perception? That is extremely important. Right, so we need to standardize his vision. And secondly, we need to make sure whether he has light perception or no light perception. Why is this important? And here we're going to now slip down a little wormhole just for interest's sake. Why is it so important? Of all the cranial nerves, you know, there's 12 cranial nerves. We'll go through them in subsequent videos because 6 of the 12 have something to do with the eye. How exciting is that? That you can, the cranial nerves are absolutely testable just through the eye. But the second cranial nerve, your optic nerve, and your olfactory nerve, the first two, number 1 and number 2, olfactory and optic nerve, are both central nerves. They are central nerves. Now, what is a central nerve? A central nerve means that it comes directly from the brain and doesn't have a myelin sheath. It is not a peripheral nerve. And the important part of that is A, it's covered with the dura, pia, and arachnoid, number 1. But the second thing is that it has no myelin sheath. And if it has no myelin sheath, it has no possibility of regeneration. Therein lies the problem. That's the big divide. So once it's dead, it's dead. It's a central nerve. It is the brain coming forward and becoming the retina. So it's the brain itself that pushes forward and becomes the retina. So if you sever the optic nerve, or the optic nerve is so damaged that it has no light perception, there's no coming back from that. So that's an extremely important thing. It's a legal term. Once you write it in a file, it's absolutely important. Because if you phone me from Upper Gulf, Bulawayo somewhere, and say to me, I have a patient here with no light perception in his one eye. What should I do? Should I send him immediately? Should I do my thing? Yeah, it's probably not so critical because the eye's dead. There's nothing you can do about it. So you must make a good diagnosis there. Very important. And all right, so with that anatomy in mind, that you've got all the meninges are covering your optic nerve right up until it hits the eye and then becomes the retina. Because of that point, a very important clinical thing comes to play here, and that is swelling of the optic disc. So when you look into the back of an eye and you see a swollen optic disc, it's very important not to willy-nilly call that papilledema, because papilledema is a diagnosis. A swelling of the disc is an observation. So you can say this guy has got a swollen optic disc. You haven't said anything about where it comes from. If you say someone has papilledema, you have made the diagnosis that he has a raised intracranial pressure, and that is massive. So let's play a little bit with optic disc swelling and papilledema. These are two important concepts that you can't just say the guy's got papilledema by looking into one eye. Why? Because papilledema is, per definition, there's very few little exceptions to this rule, but for general purposes, papilledema will be a bilateral disease. Why is it a bilateral disease? Because it is raised intracranial pressure that's pushing along the optic nerve and swelling up the disc. So it's pushing on the outside of the nerve right into the back of the eye and swelling up the disc. So you can see the swollen disc, but it has to be bilateral because the disease is not in the eye. The disease is in the brain. And therefore, it's just a window as to the space-occupying lesion or the raised intracranial pressure that's happening inside the brain. Whereas swelling of the disc. So if you say he's got swelling of the disc on both sides, left and right, bilateral swelling of the discs, this could be papilledema, no problem. But don't say he's got a unilateral papilledema. You will fail your exam, you will fail everything, and you will fail at being a good doctor. Really, really important. This is an important concept because as a junior doctor, they're going to go to you, the pediatricians are going to say, I want to do a lumbar puncture on this patient. Has he got raised intracranial pressure? Don't you want to look in the back of his eye for us? So if you look in the back of the eye and you see only swelling on the one side and not swelling on the other side, he probably doesn't have papilledema, he probably has a papillitis, or he has a nerve problem. If he has swelling in both of his eyes, then he has raised intracranial pressure, then you shouldn't be doing a lumbar puncture. Why? Because you could cone his brain into his foramen magnum and kill him, in effect. So it's very important to know that papilledema is a bilateral disease, bilateral swelling, because of the anatomy, if you understand the anatomy. So with that in mind, what will the vision be in someone with papilledema? It will probably not be very affected because it's not an eye problem. It's not an optic nerve problem. It will just be an increased blind spot, really, because there's swelling around the disc. Whereas, let's go on to papillitis and optic nerve swelling. Optic nerve head swelling from another disease, like papillitis or optic neuritis, is a very important diagnosis as well. Here we have swelling on the one side, no swelling on the other side, and you have this little bit of inflammatory things, a little bit of maybe even some bleeding swelling around the disc. And you see this, and you go back and you go, ooh, this could be papillitis. I look in the other eye. No, it's not papillitis, only on one side. It could be papilledema. So look on the one side, look on the other side. It's only on the one side. So this could be an optic neuritis or a papillitis. Now, what the difference here is that the disease process has come along the optic nerve. The optic nerve itself is swollen from normally viral causes. So you get the swelling of the disc caused by a disease that's in the optic nerve. There your problem is, well, he's going to have, we'll speak about this, he'll have a Marcus Gunn pupil, and he'll have very, very poor vision in that eye because the disease is in the optic nerve. You'll have a disease in the optic nerve. So you'll have poor vision, you'll have a positive Marcus Gunn, and it will be a completely different diagnosis, a completely different way of treating this patient. So very important that, hey? No light perception. We will still labor this point in more detail further on, but it's just important to understand why no light perception is a very important diagnosis, and that you mustn't make it willy-nilly, and especially not write it in his file unless you know that's the problem. Right, so that's the end of our first video. I hope you found that interesting. And for our next video, we're going to go to the other cranial nerves and how the pupil and the pupil reaction is a window to some very interesting diseases. See you there.